Good evening. This is Dr. John Bennett broadcasting from Miami. We're starting a Karachi Spine Conference in a few minutes. I'll turn it over to the main screen and we'll wait for them to begin. And you might hear my voice in the background until we start. This conference is put together by Dr. Salman Sharif, a well-known back surgeon or spine surgeon from Karachi. We're just waiting to begin. And now we are live. There's Hira Burham. She's one of the organizers of this conference, or she's hosting it. She actually picked up the link. She's a very serious neurosurgical student. Someone just walked by. You can cut the tension with a knife. So we get to see the backs of people's heads. Let's play. Identify that back of head. Excuse me. Here's the main tech. Here's Salman now. Salman Sharif, back surgeon. You were getting raw, uncut footage from Karachi, Pakistan. You don't know how lucky you are. Of course, all this will be edited out in the final version. We're also broadcasting on Facebook Live behind the camera. Just go to John Bennett Facebook account, John Bennett MD Facebook account. I actually started this too early, but what the heck. Franco Cervida, hi, I've never met you. I'm a friend of Vipe. We televise conferences together. Now, I don't know if you're the friend from Italy he talks about frequently. I think WF had an S. This is the behind the scenes look at the we're televising a conference of Salman Sharif in Pakistan. Oh wow, he was a head cheese of the whole thing. Wow, how you doing, Franco? I'll meet you someday. I spent 3 months with Ipe. It was very enjoyable 3 months, meeting a lot of neurosurgeons. Yeah, if you want to see the spine, Franco and others, Sammer, Vivek, Afia, go to www.neurosurgical.tv. It's on. Well, it's not on. It hasn't started yet. Like most conferences, late. There's Nicholas. Is that Nick? No. Hey, Kurt, what are you doing? Magister. Kurt, they're improving Facebook Live. Wow. Hire some people, Kurt. I'm sure you've been under the gun before. Hey, John, how you doing? Are you in AFib, Kurt? Are you back in AFib? Well, you're prepared. You're prepared. You got one of the best around, hopefully. Talking to my brother with AFib, John and Selena and Franco. My brother's an AFib in Hawaii building waterfalls, flipping in and out of AFib. But we got one of the best in California. He's going to be have a cardiac ablation done, and this guy's one of the best. Used to be at Cleveland Clinic, chairman of Cleveland Clinic ablation section. He's in San Francisco now. Andrea, I believe his name, Dr. Andrea. Excuse me.
So it's okay, it will be much difficult, but have you, for the obese patients,
Okay.
second decision will help you.
Well, I haven't done very obese patients, and I haven't done 500 cases. I've probably done so far maybe about 20 cases, and I do with one incision, and I haven't had any problems so far. I don't know.
Maybe then it will not have any problem during this surgery. Your fingers are too long.
Yeah, we know what we do is we do one skin incision and then blunt dissection.
Christian?
That's fine.
Blunt dissection. But I mean, where do you place the first skin incision compared to the second skin incision? Because the first skin incision is just like maybe 1.5 centimeters just to place the finger.
Yes.
Is it like 2 centimeters posterior to the level skin incision? All right, good.
Okay, I have a problem.
Yeah, you sure?
Yeah.
That case that you showed, it was very soft.
It's been said that in the very obese patient, it is easier to do this approach. Why? Actually, the abdomen can deviate to the other parts. Okay. I don't have much experience. Probably it may be.
Because the key point is you need the technician. So someone to say that yes, you're on the lumbar plexus or not. You check for the surgery, you won't have any rest.
What's your percentage of people running into trouble with dysesthesia and weakness? Because Louis Parmenter now doesn't do it himself.
Yeah.
He says the risks are up to 30% of weakness or dysesthesia.
But
Yours is 20.
20% of what?
1 in 5 patients having dysesthesia or weakness of thigh.
It depends on which level. You compare, let's say, 3-4. I don't monitor 3-4 at all.
3-4 is okay.
why? How can you know that you're not in the lumbar plexus?
Direct vision?
Yeah.
Shallow walking, direct vision. I go with the
No.
microscope.
Then you're placing your
The contractor.
So with the needle, you cannot injure it because it's very thin. So you just place it.
No. You place your needle there, and you have to place your vertex on there.
Yeah, but the first of all, you see on the MRI scan where is your nerve at 3-4. The nerve is usually very much backwards, and you use the anterior third, and then you go there. And I'm trying to progress now towards not even direct lateral, but oblique. And then if I go more anteriorly, and then I try to push the muscle backwards, and then I do this orthograde orthogonal maneuver, which you put your cage slightly oblique, and then you.
How can you push the muscles before how can you
You're using Medtronic, yeah? Nuvasive. Okay. Use Medtronic. Medtronic, they have very nice retractor. They have special D-lift kit, or they have O-lift kit, and they have very nice retractors. They are specially designed for that procedure. So you can put the retractors, and you see. You go there with the microscope.
I think you're right that for the chance of injury
Yeah.
is very small. It's 2%.
Yeah.
So the nerve really comes down anteriorly at 4 and 5. So
Yeah.
4 and 5 is a big issue.
4, 5, yeah, but in my hands, that's really a procedure for, if it's L4, L5 or L5S1, I'll go till it because I'm more confident with that. And I don't have any problems with fusion. If it's, usually it's adjacent segment disease, which happens at 3, 4 or 2, 3, and then I go and do that.
Okay, so we're going to move on to Nana.
Yes, it's been said by many that L4-5 level can be avoided for X-lift.
If you talk to Doug Orr, he will tell you that I don't anymore do L4, L5.
Okay,
Yeah,
actually,
because high
we
incidence
have
of
already
thigh problems.
made
Yeah.
a practice of this approach yesterday.
Me,
So my talk will be very short.
I don't.
I will repeat some of my previous slides. There are many options. I had questions about the PLIF. PLIF is something without harming the facet joint. So that
Man, oh my God, man. Oh. Oh.
with transpsotic approach, it is possible. You can place a standalone interbody cage with a transpsotic approach. I don't like to use the X-lift term. The transpsotic approach is better. TLIF is, in TLIF, you can place a cage in a banana-shaped cage by removing one facet, all of it. So then you have more space without much retraction of the root. Okay? So then a cage as large as possible may be inserted. So today's policy of spine surgeons is either to do TLIF or X-lift. A-lift is not abandoned much, but a few surgeons are doing probably. Who are doing ALIF? Yeah, not very much, huh? Probably. Do you make very often? Revisions, yes. Because in revisions, the dura may got torn, then you may have problems with the nerve injury. Okay. What's that? Please close the notebook.
Just trying to arrange the sound here. We had some technical problems. I think they're rebooting. Yes.
Curettage of the disc space, remove as much as possible, especially it is good that there is no remain of soft tissue inside. But as I said to you before, in older patients, because the bone is very osteoporotic, you can easily injure the end plate and enter the body. You cannot understand this. It is not good. It won't be very good to enter the body. Distract the space on previously placed screws. I do it always in open surgeries, but in percutaneous placed screws, it's not very easy. So then I cannot do it. Place some bone chips first, then place a bean-shaped PEEK cage, then bone chips again. Yeah, are you able to see that? These are the bone chips, then the cage, then bone chips again. This is a sandwich design grafting. Yes. It may be done by an incision 4 to 5 centimeters away from the midline, and probably 30, 40 degree angulation. Your tube, if you are doing a tube, it may be 26, 28 millimeter large diameter or 30 millimeter diameter. It depends on your preference. Docked on the facet joint. And there are also tubes that enlarge in the bottom. So then if you are using a microscope, you can look in the different edges of your view. Actually, this approach has been previously described by Wiltse approach. Wiltse has done 2 parallel paramedian incisions on the lumbar spine, opened there, and then saw the facet joints and decorticated the facets and placed some grafts removed from the iliac crest. So it was a posterolateral fusion approach without any instrumentation. And he was placing the patients in a cast or in a rigid brace afterwards, or leaving them for 1 or 2 months in the bed. So he was also providing significant fusions. Yes. Remove first inferior articular process, then a part of the superarticular process you can remove. You may not be removing the lamina, so just the facet. Yes. And these are different types of retractors. You saw yesterday with me the tubular retractor, but there is also such retractors with 4 blades. First you place with a tube, then each part of the blade enlarges inside. So then you can find a place to work in. Then you place a reamer, scratch the end place, so then the end plates are decorticated. So then you measure your this height by a guide. So according to that guide, you place one bean-shaped cage. I also prefer peak cages. This is AP view from C-arm. This is end of C-arm. Then this is the reamer, and this is the end stage. Okay, this is what I want to tell you about X-Lift. Sorry, T-Lift.
Any questions?
Everybody understood already yesterday.
So let's wrap up. Everybody
Yeah.
knows everything. Good. Thank you. So next we have Nicolai. Nicolai did not come yesterday, so all the talks today will be given back. He's going to be talking about MI screw technique.
This will. Okay. Hi, everybody. I'm going to talk to you today about screws, percutaneous screws techniques, why we're using, why we should complicate it. So that's how it started. As early as the beginning of last century, this German doctor, he put a metal for the first time in somebody's body because this kid had a TB and needed some sort of instrumentation. So this is how it started. And then this is the first recorded publication of pedicle screws. But really, this guy, Fritz Magau, he developed the contemporary concept of the screws. Initially, he started with external fixation. Then he started working with these two guys, and they have developed the modern screw that everybody is convinced now why we use it, because of a lot of benefits that we have from the modern screw systems. Let's talk about some anatomy. This is really the anatomy that you need when are you putting screw. You need to know the length of the hort. You need to know how big is your pedicle. You need to know the angle that you will insert, and you need to know how long is your pedicle. So before you start putting your screws, ideally you should measure this on the your CT scan, for example, or even MRI scan, and it's going to be easier for you to put your screws, and you will have less surprises while operating. Although, if you're very experienced, you could just do that without. And this is the anatomy of the screw. Usually you're aiming to have 80% of the length of the heart. If you surpass 80%, then you have very good pull-out strength. Although if you would like to be completely safe and if you would like to have maximum, you have to go bicortical, so 100%. You have to, usually you have about 35%, 35 mils in upper thoracic, and then goes longer when you go down. So, and this is the approach anatomy that you should know, or it is better for you to know. All these structures here that you see, you are destroying when you're doing your approach. And that is the venous anatomy, which is giving you a lot of bleeding. And I see in my department a lot of orthopedic surgeons having blood transfusion after
Surgeons and in fact, considering not patients.
the patients. But while surgeons operating patients and they need blood transfusion for their patients. They're orthopedics.
Of course. There is a paper.
Okay, but that's still a big difference. So, and this is how everybody knows how, this is how your traditional approach looks. That's what you aim. You aim to open widely. You have to expose all of your landmarks so you can put your pedicle screws. And then at the end, the spine looks like that. You find the landmarks. If you do that, you can put your pedicle screws even without a single shot of X-ray, if you're very experienced. So, but for me, at least, that is very dramatic. That is this wide exposure of the spine. I think that we are destroying a lot of structures that we need later. For our patient to be stable, to have less pain, because it's not only bones, muscles and ligaments also matter, and matter a lot. So that's why some people were thinking how they can minimize. And they came to a less invasive option, which is the cortical screws. So you see the trajectory of the cortical screw here, and the trajectory of the pedicle screw here, which is like the traditional open. And this is the difference. So if you would like to put the traditional screws, you have to open up to nearly the tip of the transverse process. If you do cortical screws, you just open up to the facet. But what if we can just restrict our approach to that line? Just that line, not even opening this or that, just that line. So this is the idea of the minimal invasive screws. You restrict yourself just to that line. You don't open, you don't cut muscles, you just split the muscles along that line, and you have everything that you need to put your screws. For me, at least, it's no-brainer if I have to choose, if I have to have pedicle screws, and if I have to. So obviously, this is the end point. We are all aiming this point, and we are choosing to go to that end point by this start or by this start. For me, it's no-brainer. If it's my back, and if it's possible, I would like to have that instead of that. So, just a few words about the concept of surgery. The concept of surgery is you have to approach a target inside your body, you have to perform the surgery, and then you have to close back what you have open already. So, and inevitably, although we follow different planes, we follow rules, we leave a lot of fingerprints, a lot of footprints, so we damage normal tissues, which then become just conjunctive tissue, so they are not functioning anymore. So that's why the normal drive of the development of the surgery is to be as less invasive as possible. And that's why we are talking about minimal invasive spine. So what is minimal invasive spine? Minimal invasive spine is a spinal procedures which are leaving the patient with less collateral tissue damage, measurable decrease of the morbidity. We're talking about the approach morbidity, faster functional recovery. Of course, we don't damage, so the functional recovery will be faster. And we are still, you remember, we are still reaching the end point. The final picture looks the same as with the open approach. And there is a lot of research now that suggests that we are right to think that we have to continue with the minimal invasive. So how the minimal invasive is achieving that? So we have to follow still rules, but we follow different rules. Instead of cutting, we are splitting, and we are not detaching the normal structures. We are just splitting. We are finding natural planes, and like that, we are possible to achieve the same endpoint. And with that, we are complicating. Of course, there is a learning curve. You have to learn how to do it. It's not easy, like anything new, but there is why. If you push yourself to learn that, you will have way less blood loss, you will have less infections, you will have less post-operative pain, your patients will stay shorter, your managers will like you, you will have less cost at the end of the day when you calculate overall, and then when you become good, you will have less surgical time as well. So that's how I started. That was my table initially. I didn't have a proper spinal table, but that did not stop me to start doing minimal invasive. That was perfectly okay for me. That was my settings. That's how I plan, for example, if I would like to put pedicle screws. If it's lumbar, usually I draw the midline, which is along the spinous processes, and then I put 2 parallel lines, and the offset normally is about 4.5 centimeters if it's lumbar spine, if in a normally built patient. But you can always measure that. You just go to your MRI scan and you measure and you see how much is your offset, and you cut exactly here. It is important to cut on the right place and with the right offset, because if you don't cut, if you cut more medially or if you cut laterally, then the structures will be pushing your instruments, and then you have higher chance to put it wrong and to get a wrong trajectory. It's not like the open. With the open, you have all the space you can manipulate, but with the minimal invasive, the skin incision actually is very important. So do it right from the beginning. Skin incision is something that you have to pay attention. And then I cut just at one go. I just stick my knife and I cut the skin and I cut the fascia, and then the rest I do just with my finger like that. So just the finger is splitting, and if you cut on the right space, you're in the Wilson plane, and that will allow you to develop the plane just with your finger without any problem. And then everything else is X-rays. You have to know how to use your X-ray, and you have to be very demanding in case you have a radiographer with you, because the radiographer should give you good pictures. If you don't have good pictures with minimal invasive, you're gonna get it wrong and you will be disappointed, because if you don't have true AP and true lateral pictures, you will be easily misled. Your screws will go in a wrong place, and then you will have the consequences. So the X-ray is really important. You have to see straight line of the end plates. You have to ask your radiographer to give you spinous process that is in the middle. So you have to be very demanding with your X-rays, and you should know how to use them. This is the Jamshidi. So basically, the next step after you develop your approach, one or the other way, you have to place your Jamshidi needle. That's the traditional and the classical way how you start and how you put your T-wire. So you need your key wire that then will be followed by your cannulated screws, and then the cannulated screws will go to the position that you want. So how we do it with the Jamshidi. So there are two types of Jamshidi that are on the market. One is so-called bevel tip, and the other one is the diamond tip. I sometimes use diamond tip only when I don't have that. Why? Because this will allow me to do very fine, very small correction of the trajectory of the screw and the key wire, respectively. Because if you get a wrong trajectory, and if you would like to get a few degrees correction, that is very difficult with that needle in case you have taken already the wrong trajectory. But if you have that bevel tip, it is easier. You can just draw it back and then rotate the needle, and then you get the right direction with only a few degrees correction. And usually that's exactly what you need when you do minimal invasive. You're not 30 degrees wrong, you're 2-3 degrees wrong. And you would like to get these 3 degrees, for example, but it's very difficult with that Jamshidi needle. But if you have bevel tip, if you rotate the Jamshidi, that will give you the correction. Respectively, you see here, I start like that. I start with my bevel going medially, and I progress the Jamshidi until I reach the medial border of the pedicle. I hope I will demonstrate that on the canvas, because speaking to you now, it's something, but it's like teaching you how to swim without me going in the pool, for example. But let's try this later. So, but the idea is that if you rotate the Jamshidi medially, the Jamshidi will have tendency to go medially and will give you that correction. If you rotate up, the bevel up, the Jamshidi will go up. So the respectively low and respectively larger. So, and then what I do is I dock my Jamshidi like that. So you dock the Jamshidi and you pierce just the cortex. And after you pierce the cortex, you need your X-rays. What's the advantage of docking the Jamshidi like that? Because when I dock the Jamshidi like that, when I do my X-rays, I am not under the beam. I'm not getting radiation. So I don't need to hold my Jamshidi. So I dock the Jamshidi like that, just hammer it slightly, and then step back and do your X-rays. And that's a good starting position. You see, that's your Jamshidi, and that is the contour of the pedicle. And that's basically the corresponding drawing. You see, that's the contour of the pedicle. You should be on the outer border of the pedicle, ideally 1-2 o'clock if it's the right pedicle, and here should be 10-11 o'clock if it's the left pedicle. And on the lateral, you have to see that picture. You have to see that you have just docked, you have just pierced the cortex. And then if you see that picture, you're happy that you can progress your Jamshidi. You progress your Jamshidi, and you start approaching the medial border of the pedicle. Usually that progression is about 2 centimeters. The pedicle usually is about 2 centimeters. So you can measure, even on AP, you can measure the length of the leftover, the one that is outside of the skin, and you can put a mark here, and then when you see the mark is below the skin, you know that you have to stop, and you have to do another X-ray. And then you have to see that kind of situation. You have to still be within the pedicle. You have to be short of the medial border of the pedicle. And you have to see that you still have distance to the posterior wall of the body. So that is how we normally progress. And then the third step will be you advance a bit more. You know that you have surpassed the pedicle. And if you have surpassed the pedicle, you have to see this kind of picture. Here, you're still short or on the medial wall of the pedicle, and here you have surpassed the posterior wall of the body. And then you're safe. If you see that picture, you know that this is the situation. You have surpassed the posterior wall of the pedicle, of the body, of the vertebra, and then you can progress safely because you will be inside the body. And then you can put your key wire, and you feel the very, very typical cracking biscuit feeling when you insert the key wire, because it goes through the cancellous bone. So, and then that's it. How you put your screws. The screw will follow the key wire, and then that's the end point. Okay.
Any questions? Everybody knows how to do the MI screws. Your indications? The screws, MI screws.
The indications.
Yeah.
You could have so whatever indications you have to put your screws. That's the indication. You can use it for trauma. You can use it for degenerative. You can use it for tumors. You can use it for anything that you use the other screws. How you do the fusion? So in case you want to do fusion, you can still open the Wilson plane and you could put. I have done this. Let's say if you have to do 1 or 2 segments, you can easily do 2 levels with, let's say, 3-4 centimeter incision both sides, and then you can open that Wilson plane and you can still put some bone graft there if you want to. But usually, if it's degenerative, you will put cage. I put cages in my degenerative spine.
That's what you're saying, that you put your finger go along the vesicle.
Yeah,
You
it's
see your MRI.
just like that.
On MRI, you've got muscles and you've got plates in between. You use those plates and you measure.
See that fat?
Given incision.
See that fat? That's the fat.
He's measured it, and you've got these planes. So it's going to come through. You can either come through this plane or you can either come through this plane. So you measure, and then you give an incision and feel the process, and you can put it in graft.
Yeah, another question.
Yeah.
How you put a rod? You pre-bend it or?
Usually I use pre-bent rod. Depends on what you're doing. If I'm doing degenerative spine, it's rarely more than 2 levels. So I have pre-bent rods, and my favorite system that I use is the Pewee Viper screws. And then I still think that if you want to put interbody cage, T-PAL is maybe the best that you have on the market. If you have on mind the instruments that they will provide, T-PAL has everything to place the cage, to place it on the right place, to remove it and replace it again in case you need that, which I don't see with the other systems. In case I do trauma, and in case I have to do more levels, I use Longitude. I think Medtronic Longitude is a very good system. You have longer screws, longer rods, which you can have pre-bent, or you can shape it yourself.
Is there any limitation of this technique?
Limitations of what you mean?
Of this technique?
So I don't do scoliosis, but people are doing scoliosis with minimally invasive.
Or what about revision surgeries?
I do revision surgery with minimal invasive. I do quite often now, let's say 1 level fixation, I extend to 2 or 3 level fixation. I still do it minimal invasive.
I think the biggest advantage here is somebody is sick and well, they've got multiple injuries, body trauma. You can put in MI screws. You don't have to use anything. You stabilize them, and then in the meantime, they can have all their treatment, etc. Yeah. That's a routine that's done in trauma centers all over the world.
And then the other thing for me is, let's say if I do degenerative, usually you have to fuse. Somebody has done a few operations before you. 1 discectomy, revision discectomy, 3rd discectomy, and then you have a lot of scar tissue. And the good thing is that everybody who is doing that is doing midline. And then when you go lateral, when you go that way, you remove that facet here, So you have pristine dura there, so you don't have adhesions. That's a very big advantage for me.
Okay, I think we're going to move on to the running short of time. Thank you.
Okay.
Quite a few number of people were asking yesterday about how to maneuver the rods into long clusters, or if you've got more than 2 levels, how to adjust them. So we're going to just add a thought by order on that. How to maneuver the rods into your screws once you put the screws in. And many people learn to start doing that. It's simple, but a little bit about how the helix comes in.
You hear me? You can.
Hello again. Everything.
I'm sorry. I was making sure he works.
Okay. So the deformity surgery is performing by orthopedic surgeons. The neurosurgeons do not the deformity surgery. It's wrong. Okay? It's really wrong. We have to also learn the deformity surgery. Okay? Yes, the orthopedic surgeons have started before us. Okay? We have to learn lots of things from them. But we have to start it. So, first of all, we have to learn about the Lenke classification so that we can talk about the common language. But I want to talk about the classifications. How do we decide which type of this curve belongs? I'm only talk about the maneuvers here. First of all, only a summary. Type 1 Lenke curves are the curves that has a main thoracic curve. Type 2 has double thoracic curves. Type 3 has a double, one is at the main thoracic and the other one is at the lumbar region. Type 4 has a triple, proximal thoracic and lumbar. And type 5 is a type that has only a lumbar curve, and type 6 has double curves, but this curve is greater than the thoracic curve. So we have to decide before the surgery where we have to start. First of all, we have to look for the shoulders. If the shoulders are balanced, we have to come 1 or 2 vertebrae above the upper end vertebra. End vertebra is the vertebra that has tilted much. So we decided this is the, let's show from this case. This vertebra is the end vertebra because it's tilted much according to the floor. So if a patient has if a patient has a balanced shoulder, we have to start 1 or 2 vertebrae above the upper end vertebra. The second one, if the patient has a right shoulder elevated vertebra, we have to go again 1 or 2 vertebrae above the end vertebra. And if the left shoulder is elevated, we have to choose the proximal thoracic spine here. And the upper instrumented vertebra is commonly has to be T2. There is no anatomical relation between the shoulder and vertebra, but why does it change during the surgery? This is a good By one of my friends, So this is the right thoracic curve. If you correct the patient during the surgery, you see when you're correcting the spine, the left shoulder elevates. Again. Let's say this is Wenger type 1 scoliosis. When you try to correct the spine, try to bring it to the midline, the left shoulder elevates. So you have to check it during the surgery. So another question, where do we have to stop? There are lots of classifications, there are lots of details here, but at the end, we have to make the distal vertebra parallel to the floor. And how do we do these surgeries? There are lots of maneuvers here. How do I perform adolescent idiopathic scoliosis cases? Before the surgery, I take a 3D CT image so that I can know which, at which level do I have to make medial, do I have to put the screws medial or laterally, so that I can decide it during the surgery. And we work two surgeons during the surgery, one on the right and one on the left side. It decreases your surgery time. One surgeon starts proximally and the other surgeon starts distally, so that we cannot stop ourselves during the surgery. So we use neuromonitoring before the surgery. We started with them, and we use freehand technique during the surgery. This scopy that we're using during the surgery is only at the end of the surgery. Why do we use C-arm? We use it to check if the shoulders are balanced after the surgery. We put two rods here, one parallel to the shoulders and one rod perpendicular to this rod, so that we can check if the patient has a coronal imbalance or not. So during the surgery, you can balance the shoulders via your distracting one side and compressing one side. And there are lots of techniques: translation, cantilever, rod rotation, and direct vertebral rotation techniques. I use rod rotation technique. This is the booth that we have from Open University. This is the concave side. That's on the concave side. You put your screws. Sorry? Good.
Not transparent. That's what it said.
Yeah.
Then you get to make it to your chair.
No. First of all, first of all, you're on the concave side here. You insert your rods here. Then you have to turn your rod 90 degrees so that you can give your thoracic kyphosis. You put your rod there, okay? Then you have to change that you want to give a thoracokyphosis, okay? So the main point here is when you turn the spine, the right side, the convex side, elevates during the surgery. So if the patient has a rib bump, you increase the rib bump during the surgery. So you have to put a less curve rod to push the rib pump down. This is the key point. The key point is you have to bend the rod less on the convex side. I'm on the concave side. We inserted the screws here. We bent the rod. We try to insert the rod to the concave side. The persuaders, the tools, are the useful tools during the surgery. Now I'm trying to turn the rod 90 degrees to the patient. So my friend tries to push the convex side down and medially so that he decreases the rib pump elevation. This is another case that I performed with my other colleague. The surgeon stands on the concave side. These are the procedures that will help you during the surgery. We put the rod on the concave side. Then my friend tries to turn the rod 90 degrees to thoracic kyphosis. And I'm pushing the convex side down and medially so that I can decrease the rib pump. Now you have to wait and be calm during the surgery because the vertebra has an elasticity during the surgery. Now, he brings the spine to the midline. During these maneuvers, you have to use neuromonitoring. Is it everything okay? Now you see the spine is coming to the midline. And I'm pushing down and medial. You see, root 90 degrees. The vertebra was here before the surgery. Now it's this is the key point. You have to push the convex side down and to medial. And this is the image, one of my friends. This is the two-rod derotation maneuver. They use two rods. It's much safer than my technique. This is the concave side, this is the convex side. And this is really a good view. The relationship between the rod rotation and the rib pump position. You will see that you turned the rods 90 degrees, then you fix the screws on the concave side. Now he's showing that how can you reduce the rib pump. Look at here. If you push it down and medially, you can reduce the rib pump. That's the way. The rod on the convex side has to be bend it less than to the concave side. And this is translation maneuver. Translation maneuver, you start from proximally and you bring the spine to the root. These persuaders are the helpful tools. The key point is here, you bend the root that you want to give after the surgery. You don't turn anything during the surgery. You bring the spine to the root here. But the key point is you have to start at the distal part. So you're coming segment by segment to the proximal part. This maneuver has some disadvantages because if the patient has a poor bone quality, your screws will pull out. And this is the vertebral segmental rotation technique. This is the cranial, this is the caudal part. So you're trying to, the vertebrae are rotated to the convex side. So we try to derotate all the segments to its normal position. So that we're fixing the distal part and we're dissecting the convex side. During that, we have to derotate the segment. The vertebra is rotated here. You have to derotate the segment to its normal position. My right hand will pull it and my left hand will push it. You see, you can decrease the rib bump during the surgery. These tools you may have difficulties during the surgery. You push it, you take it in there, you take it off there. But a practical way, if you have tools like that, this is the caudal part, this is the cranial part. The vertebra has rotated to the convex side. If you have simple tools like that, you fix the distal part, then you derotate the proximal part, step by step. The key point here is you have to fix the distal part, then you lose the proximal part, you derotate it, then fix it. Thank you so much.
Any questions? Yes.
What is the minimal age of correction of this?
What is the?
Minimum age of correction. Not a simple question.
When to start the plan?
When is, I think maybe we can discuss it there. Because that's another topic on how do you manage a patient. So that's a completely.
We will talk it.
Yeah.
You need days for that. So I think we can
Because
discuss it.
nowadays it is concepted, they are talking that we should operate early at very early age, 7, 8, 9, 10.
Let's say you have to decide it according to the patient, okay? The first one, if the degree of the curvature is greater than 50 degrees, you have to operate that patient. But the age is important there, okay? First of all, if you want to do a fusion surgeries like that, okay, you have to see that if this curve will progress or not, okay? You have a patient in, let's say, 15 years old, okay, and has a 100 degrees curvature, okay, you have to operate that. But if a patient has a 45-degree curvature that is 15 years old, you have to wait till the maturation has completed, okay? I've told only with the maneuvers there, okay? This is really a good question, but this is another topic. When we operate this patient, how do we decide it? And what we do, what we have to do
I think we need
before the
policy
surgery.
boards for that too.
Actually, We come across a lot of issues and we have to address.
Yeah, we will come next year for deformity course here, Salman.
Yeah.
Ah. Thank you.
John wants to say a few words. John Bennett is the gentleman who's from Neurosurgery TV, who's covering our talks live. So he's somewhere in California and would like to say a few words. Hi. Yes, hello.
Okay, hello. Greetings. Can you hear and see me? Okay.
On YouTube, on top of it, it's coming, it's being televised live by.
Okay. Greetings, everyone in Karachi, and thank you to Dr. Sharif for allowing me to televise this event. We're televising us live on Neurosurgical TV. And what we basically do is, with the cooperation of Salman, we televise the events when it goes on the internet. I hope other parts of the neurosurgical community in the world enjoy this. Let me just briefly show you where we're going with this technology. What we hope to do, I'm going to share the screen now and show you. This is Ivan, who you probably all know. Basically, when we televise an event like this, we want to allow the viewers to see who else is at the event. So you can IM them and you can communicate and network. You know, one of the benefits that you guys know about conferences is the ability to network. And we hope to bring that to you, televising conferences like this. So thank you, Ahmad, thank you, Hira, and thank you, Dr. Sharif, and hello to everyone in Pakistan.
Okay, John, thank you.
Thank you. It was a pleasure having you talk to us. I think we'll continue with our workshop, and we have some talks in the afternoon for you to cover as well. Thank you for connecting us.
Thank you.
I think we take a 5-minute coffee break and then off to the lab. And, everybody else knows where to go, but I think Nicola can follow it. Yeah. Can we just, yeah, this is the topic.